this wonderful sunny-ish where I am the Thursday afternoon to our virtual lunch meeting. Today's session is gelling fibre technology, the why, the what, and sponsored by L&R. And I'm pleased to be joined today by Nicola Fitzpatrick, who's a regional clinical advisor and registered nurse at L&R, and Tim Frost, who's the senior brand manager for wound care at L&R also. Tim and Nicola, we've just been talking, so can you still hear me? Are you there?
Yep. Can you hear
Fantastic.
us?
We can, yeah. So I think we are good to go. So just a tiny little bit of housekeeping, then I'm just going to talk a little bit about the format. So you can see that we're at home. We started doing these events during lockdown, actually, because the traditional way of company representatives being able to go out and get into hospitals and into district nurse bases, practices, and that sort of thing became much more difficult. So we said, actually, what happens if we take our Facebook Live format, let nurses sit at home or in their office or in their car, a few of you will no doubt be, eating sandwiches and watching some education instead of seeing the rep directly. And they've been a great success. We're looking forward to hearing from Tim and Nicola today about this gelling fibre technology. You will see, of course, that we are in our houses. So as always, if there's a technical problem, do bear with us. We've got a couple of we've got people that can sort out that in the if that does happen. Today's session does count towards CPD. We get asked that all the time, so you'll get emailed. There will be a link for you to register to get a certificate for your revalidation at the end. Do ask as many questions as you like. Some of my colleagues are there. If you've got any questions, I'll be coming back after the presentation to do a Q&A with Nicola and Tim. So, Nicola, Tim, without further ado, I'm going to hand over to you guys. Good luck. I'll see you after the presentation for the Q&A. Thank you.
Thanks, Alec, and welcome everyone. Delighted to have so many of you with us this lunchtime. So today we're going to be looking at the topic of gelling fibre technology and introducing some new product innovations in this space. Nicola's going to firstly take us back to basics. So understanding the role of exudate in wound healing. Why do we use gelling fibres? What do they do? What are they? Who should they be used on? And then I'll be excited to introduce you to two new products that we at L&R have launched this summer. So Suprasorb Liquacel Pro, and then the antimicrobial Suprasorb Liquacel AG with silver nanotechnology. At the end, Nicola's going to come back and she's going to be sharing with you the case of a quite a typical patient. We ummed and ahed as to kind of which patients to show, and we had only a few days ago, I was looking through some absolutely gruesome photos of quite a challenging grade 4 sacral pressure ulcer, and incredible results with it. But I thought for lunchtime, it's probably not one you want to be seeing when you're eating a sandwich. So we've gone for hopefully a patient that day in, day out, the type of patient you're often seeing. At the end, as Alex said, you'll have the opportunity to ask us some questions. So please, as we're going through, put these in the chat and we'll try to get to as many of them as possible at the end. So Nicola, over to you.
Thanks very much, Tim. So it's important to remember that exudate has a key role in normal wound healing, particularly when in clinical situations we tend to see the more complex and challenging scenarios. Exudate maintains the moist wound bed, allowing essential nutrients and cells to transfer over its surface, so supports cells to metabolize. Exudate helps tissue repair cells to migrate across the wound bed from the granulating and epithelializing tissue cell islands. And these islands need to fill out across the rest of the wound bed. Remember, wounds heal from the bottom up and the sides in. So exudate helps break down, so lifting and separating dead, devitalized and damaged tissue. Exudate helps break down wound detritus through the process of autolysis. With normal wound healing, exudate volume changes, and we would expect to see exudate declining through the stages of healing, with exudate levels highest at the early inflammatory phase, improving with progress through granulation and epithelializing tissue formation. You'll see a reduction in exudate with levels dropping lower as the nearer the wound healing stage is. So, we have seen that exudate directly influences the process of wound healing. Clinicians have described wound exudate as fluid coming out of the wound. It contains a variety of substances, including water, electrolytes, nutrients, inflammatory mediators, white cells, protein digesting enzymes, growth factors, and waste products. So we can see that exudate is packed with activity, as it's responsible for sending in nutrients for cell repair, supplying immune cells and growth factors, delivering inflammation components like leukocyte inflammatory components like leukocytes and fibrin, autolysis by delivering protein degrading enzyme proteases to the wound bed. Exudate has been described as fluid that, when the skin is intact, would usually bathe the cells within the dermis, providing nutrients to the cells. When there's an injury to the skin, this fluid production is exacerbated as part of the inflammatory response. So we can see exudate as an essential component of the wound healing process. Once bleeding has stopped, the blood vessels within the wound dilate. The purpose of this phase is to prevent infection, clean the wound, and provide the best conditions for healing to occur. Often referred to as destructive phase, white blood cells cleanse the wound and digest bacteria or tissue debris. These cells die and can be seen as moist, sticky tissue, otherwise known as slough. Exudate is a normal and essential vascular response following a tissue injury, and healing cannot progress without it. We don't want too little or too much. We don't want it in the wrong place or with the wrong composition. The amount of exudate is influenced by the wound healing phase, but also local factors, location of the wound, infection, depth and size. Systemic factors such as venous insufficiency, lymphatic disorders, cardiac disease, renal or liver failure can all lead to an increase in exudate. Of course, there are practical factors influencing, for example, the right product intervention, change frequency. So what we can see is effective exudate management can reduce time to healing, dressing frequency and nurse input, thereby optimizing the efficiency of care delivered. This is essential in clinical situations. The appropriate choice of wound dressing and involvement of the patient in the care plan can help to eliminate exudate-related problems. Exudate management is important to promote healing. In normal healing, the ideal situation allows the right levels of diffusion of growth and signaling factors to help cells develop and form. There is a perfect transfer of nutrition through exudate into epithelializing tissues, the perfect environment where autolytic debridement can take place. What if there's not enough exudate? We start to see a delayed healing. The wound bed dries, preventing cell migration of the essential growth factors and signaling cells. But too much exudate, this causes damage to surrounding peri-wound skin. You may see a soft white maceration, and this delays wound healing, or a red excoriation of tissue, similar to that of a chemical burn. And this can lead to the body getting stuck in the inflammatory phase of healing, with subsequent challenges to dressing selection and type. A wet saturated dressing becomes less effective. The problem of increased exudate impacts the whole person, not just the wound. Chronic wound exudate may be regarded as a wounding agent. This has a different composition, which is more corrosive than acute wound exudate and can damage the intact surrounding skin. Peri-wound damage can increase wound size and create new wounds nearby. Patient quality of life can decline, perhaps becoming housebound and socially isolated. A patient's well-being is impacted as patients focus on their wound. They may become depressed. Leakage and soiling of dressings is a problem. Saturated dressings become heavy and may restrict mobility and activity. A fear of others seeing and the loss of dignity if a dressing leaks. The dressing may even fall off. Increasing frequency of dressing change means more appointments and pressure on clinician time and budget, as well as challenging logistics for a patient. Pain, the exacerbation from wound site excoriation, the discomfort of the inflammatory phase. Wound odour can lead to feelings of shame and embarrassment, social isolation, preventing grandchildren engagement potentially. The patient with a fungating breast wound with odour, something private, becomes noticeable. Infection risk. Bacteria like to feed on exudate. Pockets multiply and the biofilm formation delays wound healing. Delayed healing leads to imbalance of growth and signalling factors. Patients can become dehydrated through fluid loss in exudate. And of course, the high exudate loss contains protein and electrolytes, so subsequent imbalance of vital components. The consequences of excessive exudate are far-reaching. As we've already considered, not all exudate is bad and is known to assist healing by providing the correct medium for tissue repair cells to migrate across the wound bed, supplying essential nutrients for cell metabolism, enabling diffusion of growth factors for wound healing, promoting autolysis. However, with excess exudate, biofilm formation can occur. And biofilm is the aggregation of bacteria often embedded within the wound. Studies have shown biofilm is present in over 78% of chronic wounds. It is most active on wound edges and peri-wound skin. Debridement is a strategy to support the immune system in combating biofilm-related infection. Debridement means removal of that bioburden from the wound. What do we see with biofilm? Well, cessation, delay in healing, little response to appropriate therapy. The healing process is impeded and exudate levels increase. Surrounding skin may become damaged. Bacteria will proliferate and mature biofilm form. The wound may become malodorous. Wound infection may develop. So reducing the bioburden in a wound with the least amount of damage to healthy tissue can tip the balance in favour of wound healing. So this leads to considering products to manage exudate. Dressings made from gelling fibre can absorb and retain significant amounts of exudate from the wound bed, controlling excess levels to reduce the risk of peri-wound damage. As exudate is absorbed into a gelling fibre dressing, a cohesive gel forms, which assists in maintaining a moist environment optimal for wound healing. This gel also acts as a protective barrier against contaminants, reducing infection risk, and it provides cushioning to reduce pain and protect against mechanical trauma. Gelling fibre dressings help remove devitalised damage and infected tissue by promoting autolytic debridement. Gelling fibres are incorporated into a variety of dressing formats. You can see in the image a ribbon for packing a cavity wound. Some gelling fibre dressings contain antimicrobial agents such as silver to reduce bacterial load. Gelling fibre dressings conform to and fill the wound bed, leaving no space or gap for bacterial growth. Likewise, they do not strongly adhere to the wound bed, allowing atraumatic, painless and safe removal in one piece. So you can see a modern gelling fibre dressing is neither a hydrocolloid or an alginate, but a separate category incorporating the benefits of both for effective exudate management. Innovation in wound dressings has been driven by advancements in material technology. This includes absorbent gelling fibres that form a gel upon contact with fluid. You can see a reminder of the key benefits we've already discussed, summarised on the screen in the blue box now. Gelling fibre dressings have evolved significantly since the inception of alginate dressings, derived from seaweed in the 1960s. The 1980s saw the introduction of hydrocolloid dressings. These combine sodium carboxymethylcellulose, CMC, derived from wood pulp with other materials to enhance wound healing and protection. The 1990s marked a significant change with the creation of highly absorbent and cohesive gelling dressings, offering improved patient comfort and wound exudate management. The 21st century has seen further development of cellulose fibre technology, including strengthening fibres and tensile strength, tailored properties including antimicrobial activity. Modern gelling fibre dressings are often multifunctional, incorporating antimicrobial agents or bioactive components to address complex wound needs. This evolution reflects a continual improvement in wound care technology. Over to you, Tim.
Thanks, Nicola. So obviously there's an existing market, and whenever a company is bringing a new product into an existing space, the question is always why, what does it do, and how is it going to help? So when we set out to look at the gelling fibre sector and seek to bring a new product into the space, that was our key aim. How could we develop a dressing that firstly fulfilled the clinical need, as Nicola has said, but also improved on those already in the market? So what are the key needs for a gelling fibre dressing? Well, it needs to absorb, it needs to retain. But then we also wanted to overcome some of the existing limitations of gelling fibres, such as dressing shrinkage and contraction when wet. So I'm really excited to introduce you to Suprasorb Liquacel Pro. We launched it this summer, so it's very, very new in the market. It's just been launched onto prescription, so it is available to use now with your patients. Suprasorb Liquacel Pro, it's a soft absorbent primary wound dressing, and it's made up of that combination of sodium carboxymethyl cellulose and then lyocell strengthening fibres. Both of these are made from cellulose, and they're used to manage exudate in the wound bed. The cellulose we source from sustainable forests, typically eucalyptus, and we also manufacture in the UK. So we're really keen to make sure this product is as sustainable as possible. As a gelling fibre, it absorbs exudate from the wound, it forms that gel on contact with the wound fluid, and then it also retains that fluid even under compression. The gel dressing, it will maintain that optimum moist wound healing environment, so supporting that wound healing, as Nicola said, but also enabling autolytic debridement to take place. The gel will lock away the bacteria and cell debris, as well as the exudate. It will take it away, lock it away in the dressing, so that it's removed when the dressing is changed. The gel, when CMC fibres gel, that gel enables it to closely conform to the wound bed. So you don't have those kind of dead spaces where, for example, exudate might pool or bacteria, for example, could start to colonize and grow. In the design of Liquacel Pro, we set out to design a dressing that really was different to the existing market leader. So rather than using the stitch bonding, which many of you might be familiar with, we hold our CMC fibres together by incorporating it with the strengthening fibres. So throughout the dressing, you have that homogeneous combination blend of the CMC and the strengthening fibres. This enables the strength that you would expect to get that one-piece removal and strengthen the dressing, but also reduces some of those challenges, so that constriction and that shrinkage that kind of typically you'll see with other CMC fibres. So to summarize really what that means for your patient's wounds, well, this gel technology, in being able to lock away exudate and excess harmful proteases, what it means is that wound is helped in its progression. As Nicola said, exudate, whilst we do need kind of that balance of exudate in a wound, too much, and you can delay that wound healing. The bacterial load, as I say, is also locked away into the dressing, and the dressing, we would say, is a bacteriostatic. So if the wound is infected, Suprasorb Liquacel AG would be the dressing of choice. As I said, though, only the wound should be shrinking. The dressing should stay stable, and it should not be shrinking down when it's wet. For this reason, our structure enables Liquacel Pro to have minimal shrinkage whilst still ensuring that one-piece removal. So the wound bed has that full contact with the dressing throughout its use. Finally, we know that many of these patients who have gelling fibre dressings on their wound, they often have quite variable levels of exudate and often excess exudate that needs to be managed. So excess exudate is able to vertically absorb through the dressing and upwards into the secondary dressing, but it's not allowed to spread laterally. So this protects the wound edges from maceration or excoriation. The Suprasorb Liquacel Pro, it's indicated for wounds that have exudate that need management. So typical wounds and non-typical wounds, so chronic wounds, leg ulcers, DFUs, pressure ulcers, or acute wounds such as post-op or trauma wounds. The key is making sure it's a suitable dressing for the exudate. So moderate to very high exudate would be where you're looking for indications. So So in launching a new product into an established category, as I said, we're very keen to make sure that this product performs better than the current market leader. So how do we know this? Well, obviously we can test it. We can look at some of these in vitro assessment tests. And here you can see some results completed by the independent SMTL labs. So firstly, we looked at how Suprasorb Liquacel Pro performed on fluid handling. So this is referred to on the left-hand side where you've got the graphs there. And Liquacel Pro is referred to as dressing A in green. So free swell absorbency, this refers to a dressing's ability to absorb fluid, so stimulating exudate from the wound bed. And under standardized test method, you can see very clearly that Suprasorb Liquacel Pro has greater absorbency of fluid. We've said, and kind of both Nicola and I have mentioned about that importance of keeping the exudate retained in the dressing, confining it to the wound area, but whilst also allowing the excess to move vertically away from the wound bed. We've shown that even when under force, so for example, when used under compression, bandaging, fluid is retained in the dressing at a higher rate than the market leader. We've also completed physical testing on the dressing as well. So I think probably everyone who's used the gelling fibre dressing in the past have experienced that CMC fibres are very good at gelling and swelling when they're wet. But this also can mean that they pull in and they shrink down. And often the use of external stitching can cause that constriction of the dressing. Whilst clinical guidance is to leave a significant overlap to reduce this risk, in practice, this is not always feasible, particularly in difficult to dress areas, or, for example, if packing a wound, a deeper wound, for example. It relies upon that clinical knowledge to compensate. So we've tested, and Suprasorb Liquacel Pro has non-woven strengthening fibres throughout the dressing. This means that when it gets wet, you will experience minimal shrinkage compared to the market lead, which I think you can see there shrunk by nearly 30%. Finally, from a physical testing point of view, we know that strengthening fibres are key, because when an increasing force is applied, so for example, when removing a dressing from a wound or removing it from a cavity wound, the dressing needs to stay intact, and you need to ensure that CMC fibres come with the dressing. And we've shown that even without those external stitches, instead by incorporating those strengthening fibres into the textile, we have that strength to enable one-piece removal. We've also completed testing on Suprasorb Liquacel Pro across the full market range. So just to highlight here again with fluid handling, we are showing superior performance against the rest of the marketed products. We've not named them in this study. Obviously, we've tested the full range of UK products, and Liquacel Pro is the one there at the top, dressing A. We can show that greater absorbency and a higher volume retention of fluid and fluid retained. Nicola mentioned earlier, though, about the challenge of infection and delayed wound healing, particularly when there's a bioburden in the wound bed. So when developing Suprasorb Liquacel Pro, we also set out to look at a biofilm solution, so a dressing that can manage those challenges of bioburden and that challenge of infection. So we've taken the benefits of Suprasorb Liquacel Pro and we've incorporated an effective antimicrobial agent to provide your patients a dressing solution to manage this biofilm challenge. So I think, as many of you might be aware, there's different oxidation states of silver, Ag+, ionic silver, there's Ag2+, there's Ag3+. The singly charged silver Ag+, or 1+, is typically considered the most biologically active, and I think typically Ag2+ or 3+ is more likely to form insoluble complexes, and it's rapidly inactivated by other molecules in tissues and wound exudate. So for this reason, we set out to use the ionic Ag1+. And our silver nanotechnology incorporates silver nanoparticles throughout the dressing. And when these are in contact with fluid, they release silver ions in a steady and consistent rate. We've completed multiple kind of bacterial and biofilm testing with this dressing and the nanoparticles, which really show that the silver particles, they have a 99.9% kill rate across the full broad range of common wound microbials. So be that MRSA, Pseudomonas, Staphylococcus, yeasts. In models stimulating wound biofilm, we've also demonstrated this effective kill rate and reduction. Patient safety is often a concern with antimicrobials, and there's a lot of work around antimicrobial stewardship and how topical antimicrobials as well as systemic antibiotics should be used effectively, but also safely in a clear way. Suprasorb Liquacel AG, we've shown it in the labs and on various models. It has that safe and low cytotoxicity profile with a slow and steady and consistent release of silver. Obviously, with the Suprasorb Liquacel Pro, we've got a number of benefits around exudate management that we've been able to carry over to the Suprasorb Liquacel AG. So for our patients' wounds, we see all those same benefits of moist wound healing. We maximise the absorbency and retention whilst minimising the shrinkage of the dressing. The silver nanotechnology, however, also provides that antimicrobial effect. The CMC fibres are able to lock away the bacteria and exudate within the dressing, protecting the peri-wound skin, and then the silver nanotechnology is able to kill the bacteria and destroy the biofilm. With any new product, particularly antimicrobials, we really want to see them in action. I know that probably many of you are listening to me, and what you're thinking is, I want to give it a go. So this is a brand new product. We launched it this summer. Like the Liquacel Pro, we launched both of them over the summer. So they're both now available for you to order and to use. But here you can see the results of one of the launch studies that we've done. And this is just a kind of top line summary of some of the kind of key findings. In this, we observed data on patients with a variety of hard to heal wounds, all with moderate to very high exudate, using standard of care. The average age, I think, was around 67, and the treatment lasted between 7 and 28 days, as dictated by the clinician seeing that patient and the clinical need for antibacterial dressing. So the study set out to demonstrate the dressing was able to perform the clinical aims for the patient. So we can see, for example, on bacterial aims, it was effective in preventing infection, reducing or fully clearing the biofilm in, I think, 91% of the patients. We had that full or partial reduction. And we also saw significant reduction in all of those inflammatory signs associated with bacteria in a wound bed. On exudate handling, we see that, again, all the treatment aims were achieved. So nearly all patients had that autolytic debridement, moist wound healing occurred, protection of the wound edges. On the physical properties of the dressing, all the wounds, for example, had atraumatic removal. All the wounds had one-piece removal due to those strengthening fibres. And over the last few years, a number of consensuses have been launched, which really have been focusing not just on antimicrobial dressings, not just on managing bacteria, but really empowering biofilm-based care and encouraging that wound progression in hard-to-heal wounds. Clinical best practice indicates that a combination of strategies is key in getting on top of that biofilm challenge. Wound bed preparation should therefore take in a wound cleanse using saline, surfactants, or even just water to eliminate as far as possible those surface contaminants. Debridement should then occur, and this is both on the wound bed and the wound edges. And at L&R, we can support this with our market-leading Debrisoft pad or lolly, which has nice guidance for its use of debridement, particularly in biofilms. Finally, the wound should then be dressed with an antimicrobial dressing. And the launch of a Liquacel AG, you can be confident in its ability to manage this bioburden and progress these wounds towards healing. I also want to share here, though, that product selection should not be done in isolation. Clinicians can follow exudate pathways or continuums to select the most suitable primary and secondary dressing to manage a patient's wound. At different levels of exudate and at different stages of a wound, different dressings may be required to manage the challenge, whether that's a secondary on its own or a secondary with a primary, such as a gelling fibre. At L&R, you can see we have this full portfolio of products which all work together to help your patient wherever they are on that wound healing journey. So just as a reminder, at the end of this session, we'll have time for questions. So please keep putting them into the chat. And at the end, we'll do our best to get through as many of them as possible. I'd now like to hand back to Nicola, who's going to take you through a patient journey using products such as these.
And this is actually very recent, as you'll see by the dates on the pictures. So introducing a 77-year-old female with no significant past medical history. She lives with her husband, who has dementia. She's also his carer. Both are unable to drive, so family members supported transport to appointments and caring for her husband while she was doing this. Unfortunately, she fell in her garage, fractured her wrist, and grazed her leg. A week later, her graze was not healed. So she went to the GP, who dressed with a foam and started oral antibiotics. The wound was then cleaned and redressed 2 to 3 times a week. However, it deteriorated into a deep cavity, exudate increasing over the next 6 weeks. A silver dressing was used for a 2-week period during this initial time, and the wound did show some improvement. However, the wound then declined again. So at 6 weeks, with the wound area extending, our involvement starts. And the first picture taken in early July, you'll see there on the left hand of the screen. It was clear to see that excess exudate isn't being managed and preventing the wound progressing to healing. This wound had grown in size, developed a deep cavity, was sloughy and wet and become infected. You can see peri-wound skin becoming damaged and different tissue types within the wound. A dressing was needed to absorb and lock in exudate, removing the excess and debris and keeping it away without releasing or shedding its own fibres. So the dressing selection needed to protect wound edges with no shrinkage when in situ. So Debrasoft pad and Lolly mechanical debridement tools were used for wound bed preparation and biofilm management. And then the Suprasorb Liquacel AG ribbon and 5x5 covered with a Suprasorb P sensitive silicone foam dressing was used. Progress could now be seen, only with a slight halt to proceedings when a nurse changed dressing approach, which was reverted at the next appointment back to Suprasorb Liquacel Pro, which then continued twice weekly. You can see wound depth and size reducing and inflammatory exudate response declining. So the images you can now see are the start point where we came into the scene and finish. A dry and healed wound after 6 weeks treatment. So effective management was achieved with the gelling fibre introduction. I will add that compression has been commenced. In total, the lady's journey with her wound was 12 weeks, and we can see the challenge of excess exudate that led to the delayed healing. This lady likes having nice legs, so was impacted by this large leaking wound. It reduced her mobility and social desire, particularly to care for her grandchildren during the school holidays. Attending clinics meant reliance on family members to support her husband while she was out and transport to appointments. So I think, as all case studies, there's always a key learning, and it's important to assess the wound. Select the dressing that promotes wound healing, remembering the wound is part of a whole person. There is a need to use our knowledge on wound healing to direct our dressing choices and holistic patient care. So absolutely appreciate, we've covered rather a lot in a very short space of time. So I don't know if you have your phone available to you, you can see in front of you a QR code. And this is in fact for our Learn on Demand app. It's an absolutely fantastic free educational resource, which is available to you at any time of day. Not only does it provide access to RCN accredited modules, but also further information on our L&R products. I'll just leave that there for a minute, just so you can take that information. We also have, if you've already signed up to Learn on Demand, within there we have a couple of links that are really appropriate to today. You can see there's a QR code for exudate management and also a biofilm management course, which are RCN accredited. So again, I'll just pause for a minute so you can take hold of those. Back to you, Tim.
Thanks, Nicola. So I hope you are all very excited to try this brand new product. Nicola shared with you a case study which hopefully kind of standard care, you would see progress. But as we know, often there can be mixed products used, there can be changes to treatment plan, and that wound can regress when treatment is changed. And we saw that in the second picture where they changed to a different treatment plan, and unfortunately the wound went back until they changed back to the Liquacel AG. We're seeing those amazing results across the UK, and I'm sure if you're going to any of the kind of upcoming conferences and events, you'll start to see some of these kind of case studies and other patient stories being published. We're soon to publish also a supplement to the Journal of Wound Care, which goes into a lot more detail about Liquacel Pro and Suprasorb Liquacel AG. And it also includes a case series following quite a number of very complex, challenging wounds from a complex wound clinic and a couple of podiatry groups. So I hope what I've shared excites you. This is a product that we want you to go out and try. We want you to give it a go, compare it to the gelling fibre that you might be using already, and see the results for yourself. So on screen, you can see a QR code that should connect you to our website. And I think we'll put a link in the send out after this as well. Get in touch and give it a go for yourself. So Alec, over to you with the questions.
Thank you both. Very interesting. Yeah, very good. So the product's available now.
Yeah.
And the QR code that you just put up, people can scan that. And what does that do? Does that get them in touch with the local rep, or can they order samples? What actually happens?
So exactly that. That will take us through to our website where you can put your contact details in, and our customer service team will get back in touch with you and can either put you in touch with the local rep or potentially send out some samples for you to try.
Fantastic. Okay. Well, it looks very good. Case studies were great. Cheers, Nicola. There's lots of questions that have come in, so we'll get straight onto those and let people get off and maybe might get time to have another cup of tea before they get back to work. So the first question is, what is the difference between nano silver particles and ionic silver? Are they the same? Who'd like to answer that?
That's a great question. So silver comes in many forms. For it to be active, that's the ionic form. So you might have a silver salt, you might have, I mean, if we think about all the different types of silver that are in different dressings, nanoparticles is the form that we have the silver in the dressing. The speed that those active silvers or the antimicrobial kind of activity can occur is how quickly those inactive silver salts or silver particles are made into that active form. And with the nanotechnology in Suprasorb Liquacel AG, we've shown that this happens absolutely at speed, but not so much that it can cause damage. So it can get quite a complex subject. I will say the chemistry of how silvers work. But if you are interested, follow up and we can share further information. We can share some of the studies that have been done.
Brilliant. Thank you. Next question. This is quite direct, actually. It says, "What makes Liquacel better than other gelling fibers than other gelling fibers on the market?" I know there were some case studies and some evidence you saw around some of the testing, but if you had to sum it up, what would you say makes it better than other gelling fibers on the market?
Yeah, I mean that's a really good question. It's obviously we're coming into a market with several big players who have very established brands. We've shown you some of the lab testing that we've done, really demonstrating that on absorbency and retention, those two key things that you need a gelling fibre to do to lock away the fluid whilst also keeping that wound moist. We have greater absorbency and we have greater fluid retention. We've also shown shrinkage is something that for many of you out there as healthcare professionals, you may find that your dressing shrinks down, exposing those wound edges, opening up the risk of maceration or excoriation where fluid can leak out. Liquacel Pro has much lower shrinkage, has very minimal shrinkage compared to the market leaders. And so you're going to get that wound edge protection. Oh, sorry, I should have said as well, obviously in the NHS, we are very budget driven. The current climate, cost is a real concern, and we've brought it out at a very favourable price.
I was just about to ask you. I thought that might have been one of the key factors as to why it was a better dressing.
Yeah, I mean, Alec, I think the reality is obviously budget is always going to be a concern for the NHS, for the payers, for even kind of clinicians on the ground. Cost has to come into it. We are very keen, though, that this isn't just a cost product. It's not a budget swap. It is a clinical reason to change.
Brilliant. Okay. So when should I stop using Liquacel AG? Is it after 2 weeks?
Shall I answer this one, Tim? Really based on nursing assessment. So we would actually recommend you reassess your wound every 2 weeks. So it is not rigid that the silver component has to be in place for 2 weeks. It's actually about your assessment, and it's looking for those signs we discussed earlier about sort of biofilm, those covert and overt signs. So, redness, pain, swelling, the colour of the exudate, and the amount.
Okay, thank you very much. Number 4, are MMPs and biofilm the same thing? Nicola, do you want to take that one?
No, they're not. Your MMP is your protease, and your biofilm is your aggregate of your bacteria. Is that a short answer? Would you like to make it longer?
Yeah, no, that's good. I was saying earlier, I just thought when you said that, I was like, oh, that's a good one, because we're going to take the video today. So if you join us late or something, then you'll be able to watch this back on Facebook within, like, immediately. You can go back to the beginning, and they'll be on our website from tomorrow. But what we're also going to do is we're going to take the video and cut it into small, sort of bite-sized chunks. So you'll see it on our social media and stuff over the next couple of weeks. And that answer you just gave is perfect for a little, for a little Instagram post. So brilliant. Right, okay, there's a couple more questions. Number 5. How long should it take to remove biofilm from a wound?
We were both about to speak there, weren't we, Tim? I was just going to say, obviously, a biofilm management and the pathway, again, we really focus on that best practice. And what we would be looking at with biofilm is actually we can get really, by actually using, say, for something like Suprasorb, only takes a couple of minutes, and actually we have a really big impact on that wound and the amount that we can lift off. So what we would be looking at is at dressing changes, we would be looking at that mechanical debridement. And initially, obviously, looking over those 2 weeks, so potentially 2 times a week, could be 3 times a week if we're in a really difficult situation. But obviously, it's all about best practice, that reassessment and looking at our wound and making those observations.
Yeah, and I mean, with the observational study, we saw a mixture. So those patients were observed for between 7 and 28 days. That was the study, kind of how it was set up. And for some of those patients, within the 7 days, they were seeing full biofilm removal with just the Liquacel AG. For some patients, it took a few more dressing changes. It entirely depends on that patient's wounds, kind of how mature the biofilm is, and what else is going on with that patient. But what I would say is, as Nicola says, reassess. If needed, continue treatment, but you should be seeing results within a week. You should be seeing that progress.
Thank you both. I think this is probably the final question, and then we'll wrap it up. And I can probably answer this. It says, I'd like to evaluate both products. How can I go about this? And we've talked about it, right? So there's a QR code. We will stick the QR code back up on screen at the end of this presentation. So do get on there. And also, if you visit our website, which is www.jcn.co.uk, you'll see a list of the events that we're attending, that we have between now and the end of the year. We're in York, Durham, Peterborough and Blackpool, so that's all up north for me. And Eleanor are one of our sponsors, so they'll be coming along to each of those events, and they'll have a stand, so you'll be able to come and actually visit those events and speak with the local teams directly, and actually see the product and ask any of these questions that you like face to face as well. So please do check out the website. Tim, Nicola, thank you very much for that. It seems slightly odd, doesn't it, doing one of these in the middle of the afternoon rather than at 7:30 at night and having a glass of wine waiting for us when we finish. But it's been really fascinating. So thank you very much. Thank you to all of the team behind the screen that you don't see. There's a lot of people working on this, so thank you very much for that. And last but not least, more importantly, thank you to every single one of you that has stopped what you're doing to join us. We'll send out. There'll be a link coming up on screen so that you can download your certificate. Do scan the QR code. Check out the product. It's a really interesting product, actually, and And I'm interested to hear feedback from when people start using it en masse. So have a great afternoon. Enjoy the rest of your week and have a great weekend. Tim, Nicola, I shall see you soon. And that's it. Goodbye.
Thanks, everyone.